Okay, we're back from our break, so we could continue with pulmonary. I want to just answer a couple of the questions that people had on the prior case of asthma. We defined asthma as an inflammatory process. So in the chronic treatment of asthma, the most important treatment, the most important drug to use is some type of steroid, usually in the form of inhaled steroids. So an inflammatory process needs steroids. In the acute exacerbation, giving the patient steroids, oral steroids, or even IV steroids, takes, we said, about 24 to 48 hours for this to act. So the most important thing in the acute exacerbation is giving adequate bronchodilation with albuterol or some form of bronchodilators. So that's the important thing. The second thing that some people had a question about is when you use methacholine, even if you use it in normal people, you will get some decrease in FEV1 over FEC. This should be about 5, 4%, 6%. If you go back to our case, in case number 2, the person there had an FEV1 over FEC something like 83, 84% of predicted. When we gave her the methacholine challenge, it went down to 48% of predicted. So there was a significant drop. She dropped almost half of her FEV1 over FEC. So this significant drop, over 15, 20% of what the patient had before, means that she has reactive airways asthma. Okay? So that's clear. Remember, when we measure obstructive diseases, we want to measure airflow. So when we diagnose from the pulmonary function test asthma and chronic obstructive lung disease, these are diseases that have problem with air movement. They can't move air out of the lung. That's why the air gets trapped in the lung. That's why you have the hyperinflated lungs and the flattened diaphragmatic surfaces. So chronic obstructive lung disease and asthma has a problem with airflow movement. So when you measure the pulmonary function test, they would have abnormal indices of airflow movement. What are the parameters that measure airflow in the pulmonary function test? FEV1 over FEC, that ratio, that's one, and the other one is forced expiratory flow, 25-75. That's also a ratio. It measures a ratio of FEC. So these are parameters. These are indices of airflow. They should be decreased in asthma and chronic obstructive lung disease. Okay? Not the total lung capacity, not the residual value. That should be decreased in diseases like restrictive diseases. We will talk about these diseases a little bit later today. Okay? Very good. So let's go further down, and we're going to be talking now case 3. This is another form of obstructive lung disease. So this 65-year-old man comes to your office with worsening dyspnea on exertion over the last year. He was recently treated for an episode of infectious bronchitis characterized by fever and productive cough. He now has a persistent mild non-productive cough. He notes a 10-pound weight loss over the last year and has increasingly restricted his activities because of respiratory compromise. He feels short of breath. He has history of smoking 2 packs per day for 50 years. So that's almost a 100-pack-year history, right? 2 packs a day, 50 years, but denies alcohol intake. His temperature is 37, blood pressure 150 over 80. The pulse is 90 per minute. The respirations are 28 per minute. He is thin and frail, using accessory muscle respiration at rest. He's sitting in a tripod position, so they sit like this and they breathe really quickly. Examination shows no sinus tenderness, decreased breath sounds with scattered bronchi, increased anterior-posterior diameter. Right? So when they talk about increased anterior-posterior diameter, they usually talk about obstructive diseases. They usually have hyperinflated lungs. That's why the diameter is increased. And hyperresonance to percussion. His cardiac impulse is visible in the subxiphoid area. There is regular rhythm, distant heart sounds, and an increased S2. His abdomen is soft. non-tender, with no hepatosplenomegaly, and examination of the extremity shows no cyanosis and no edema. So this is the classic presentation of somebody who has some form of chronic obstructive lung disease, a smoking history, hyperinflated lungs on the examination, increased right-sided heart sounds, increased S2 because of the pulmonary hypertension. You transmit the pulmonary hypertension to the right side of the heart, and eventually these people develop right-sided heart failure, cor pulmonale. So that's why you get this increased S2. Now, so emphysema and chronic bronchitis should be at the top of your list. Now, how do we define these two diseases? Emphysema is defined as permanent dilatation of the terminal bronchioles to the alveolar membrane. So in this case of emphysema, you have destruction of the alveolar membranes. Now that's important because on the pulmonary function test, we just showed before, we measured airflow, right? That's FEV1 over FVC or FEF 2575. We measure total lung capacity and residual volumes. These are static volumes that usually correlate with restrictive diseases when they're decreased. And we also measure the diffusing lung capacity. We give the patient carbon monoxide and we measure how well it diffuses across the alveolar membrane. Here's carbon monoxide. So it should diffuse, if there's nothing wrong with the alveolar membrane, it should diffuse along these vessels really quick. That's what we use. That's the test. And this is called the DLCO. So any disease that would affect the alveolar membrane would have a decreased diffusing lung capacity. I just defined as emphysema as destruction of the alveolar membrane. Here it is. It dilates. And it scars and gets destroyed. So the diffusing lung capacity in these patients would be, by definition, decreased. This is the only obstructive disease, if you have clear-cut emphysema, that causes diffusing lung capacity to be decreased. And the reason is because of the definition of emphysema. That is, there's destruction and permanent dilatation of the alveolar membranes. Chronic bronchitis, on the other hand, if it's clear-cut chronic bronchitis, there is no effect on the alveolar membrane. Now, I said if there's clear-cut chronic bronchitis, most of the patients that we see in clinical practice have some emphysema and some chronic bronchitis. That's the classic patient we see. That's why we call these together chronic obstructive lung disease. We don't differentiate, we treat them the same way. But for the pulmonary function test and for the boards, you need to know that chronic bronchitis, this is emphysema here, chronic bronchitis has, if it's clear-cut chronic bronchitis, the DLCO is normal. And chronic bronchitis is defined as productive cough for 2-3 months out of the year for consecutive years. So this is a clinical diagnosis. This is more of pathology. It refers to the alveolar membrane. But we could still diagnose emphysema clinically, especially when there's evidence on the pulmonary function test of a decreased DLCO. So these two things should be on the top of your list. Now, asthma would do this, but asthma doesn't occur in 65-year-olds all of a sudden. Sometimes it does. It's rare for this to happen. It doesn't always occur there. They usually have long history of asthma before. And this patient with the smoking history and the stuff with the increased S2 and the chronic productive cough and the infections would make this less likely. Congestive heart failure is a possibility in this patient. So that's something to think about. We should have jugular venous distension. We should have an apical impulse that's displaced. Usually it's systolic dysfunction that we see. And of course, angina. In a smoker, 65-year-old person, you definitely think of angina. Angina usually occurs, though, stable angina means usually what? Chest pain with exertion. Chest pain, chest discomfort. Not so much shortness of breath. Post-obstructive pneumonia they thought about, but this usually is a more chronic process that usually means productive cough, fevers, and so forth. And they thought about sarcoidosis. Sometimes this does it too, but we shouldn't have seen the AP diameter increase, the classic symptoms of chronic obstructive lung disease. So in this patient, you want to diagnose the disease. You want to diagnose the disease. You want to see what this patient has. You want to rule out some other stuff, but you want to diagnose the disease. So what's the best diagnostic test to do in chronic obstructive lung disease when you're considering chronic obstructive lung disease? These are the pulmonary function tests. Just like we did with the asthmatic patient. What should we see? We should see the same things we saw with asthma. We should see an FEV1 over FVC that is decreased. We should see an FEF 2575 that is also decreased, and we may see a total lung capacity that's a little bit increased and the residual volume increased a little bit because of the air trapping. So this doesn't look any different than asthma. Doesn't look any different, may not look any different than asthma. So your goal here is to show that it's not reversible. By definition, chronic obstructive lung disease, when compared to asthma, are not reversible. There's no reversibility. So here you go. You give this patient albuterol. Remember how our asthmatic patient went from 50% of predicted up to 85% of predicted? Look at this patient. This patient had 50% of predicted, and we gave her the albuterol, and now FEV1 over FVC went maybe to 55% of predicted. Maybe no change at all. No change. Minimal change. The FEF 2575, let's say, had 45% of predicted, remained 45% of predicted. So you see no change at all. No significant change. That's the definition of chronic obstructive lung disease. An obstructive pattern that is not reversible. Even though asthma and chronic obstructive lung disease both are obstructive diseases, they have nothing else in common. Asthma is usually a benign disease. This is a progressive disease, especially if you don't stop the smoking. So they have nothing in common. They may look the same initially on the pulmonary function test, but they have nothing in common. Don't get those two mixed up. Asthma is different. Chronic obstructive lung disease is something different. I always see on the physicals they say asthma/chronic bronchitis. No. The patient has either chronic bronchitis or asthma. There are a few patients that have both, but this is different. Also, it's not only that this is non-reversible. Non-reversible. Here you go. We just diagnosed this. But it's also, there's not an inflammatory component. There's no chronic inflammation here. So what does that mean? No steroids. Steroids don't have an effect here. Like asthma, no steroids. This is no chronic inflammation, so steroids should not be used here on the chronic basis. There's no inflammatory component here. So that's another big difference. The other big difference is, if this patient had emphysema, on the pulmonary function test, what will we see here also? We'll see the DLCO show what? Decreased. So this is emphysema, and this doesn't change at all when you give the patient albuterol. Doesn't change because the alveolar membrane is destroyed. Now this is emphysema, but this is chronic bronchitis. So chronic bronchitis has the same initial pulmonary function test as asthma. There's no difference, except that when you give the albuterol inhaler, there's no change in the pattern. So this is chronic bronchitis or emphysema. It's called chronic obstructive lung disease. The definition of emphysema is a destruction and permanent dilatation of the alveolar membranes, and thus you should see DLCO decreased, diffusing capacity. Chronic bronchitis is productive cough for 2-3 months out of a year for consecutive years. You should see normal DLCO and non-reversibility in both of these when you do the pulmonary function test. That's the way you diagnose them. Now, that's what they did here, and the initial diagnostic plan here, if you go down to case 3, on the bottom of the first page of case 3, the pulmonary function test is the diagnostic test of choice. In the case of emphysema, it shows non-reversible obstruction with DLCO. If this patient had asthma, FEV1 would be decreased but would reverse with a bronchodilator. That's the bottom line here. You also do a chest x-ray to diagnose other things, and you see the results a little bit later. The decreased FEV1 over FEC and the FEF 25-75, and the DLCO is decreased. And when you give the patient bronchodilator, it doesn't change. So this patient, by definition here, has what? Emphysema. The DLCO is decreased. So by definition, this patient has emphysema. On the chest x-ray, you want to make sure this patient doesn't have anything else on top of this. You find flat diaphragmatic surfaces, narrow cardiac silhouette, apical bullae, no infiltrates are noted. So you virtually rule out congestive heart failure, you rule out the post-obstructive pneumonia that we talked about before, and so forth. This is the classic pattern that you see on the chest x-ray of chronic obstructive lung disease. If the patient, if you do an x-ray, this is indicative of chronic obstructive lung disease, but the diagnostic test of choice always is the pulmonary function test. You do an arterial blood gas, and look what this patient has. Has 7.42, the CO2 is 40, and the oxygen is 74. Now, patients with chronic bronchitis don't have an ABG that looks like that. This is the classic ABG that we see in patients with emphysema. And let me write that down here, because we need to compare both. This is the one that they gave us, 7.42, so almost normal, and they gave us 40 and 74. So almost normal parameters. So you look at this person, they're breathing really fast, they don't look good, but you look at their ABG and it looks virtually almost normal, with a mild hypoxemia, almost normal. So this is the characteristic finding in emphysema. Because these patients breathe quick, they keep up minute ventilation. They sit down and they breathe really quick. They have an almost normal arterial blood gas. So this is the classic pattern that we see with emphysema. So they look clinically bad, but their ABG looks almost normal. They want you to know this difference. Because if you take a patient with chronic bronchitis and you do an ABG on this person, this is what you're going to find. You're going to find marked acidemia. You're going to find marked CO2 retention. This is the CO2 here. And marked hypoxemia. This is the classic pattern of chronic bronchitis. They retain CO2. But then you look at them clinically. And they look comfortable. So the emphysema, the clear-cut emphysema patient, clinically looks uncomfortable, but their ABG is almost normal, and that has to do with keeping up minute ventilation. The patient with chronic bronchitis, clear-cut chronic bronchitis, looks clinically comfortable, but when you look at their ABG, there's marked abnormalities here. Now, the problem is that some physicians look at this ABG and they give them oxygen. Let's say 4 liters per minute. They want to correct this. And what happens to these patients who are chronic CO2 retainers? That's right. You block their O2 drive, so they now stop to breathe. So all of a sudden, you try to do something good, and what happens is they retain more and more CO2. So look at this CO2. Well, their oxygen got better, right, because you gave them the 4 liters per minute, but look at their CO2. Most patients, most normal patients, their drive is related to CO2. Most normal patients, most normal people, I should say. People with chronic obstructive lung disease, especially chronic bronchitis, because of the chronic CO2 retention, their drive is analogous to oxygen. So if you give them a lot of oxygen, you blunt their respiratory drive, and they start to stop to breathe. They breathe slower. They retain more and more carbon dioxide. So be careful. These people should not be given a lot of oxygen. Should not. This is where they live, 60-60 range. 60 CO2, 60 O2. If they're comfortable, you leave them alone. Okay? Or, if you decide to give them oxygen, you give them low-flow oxygen, 1 liter per minute or so. You don't give them a lot of oxygen, you're going to get them sick. Okay? Very good. So, going back here, this patient has emphysema, and one of the other things that we think about, as we did with asthma, after we diagnose it, one of the things that causes COPD exacerbation is infections. So infections, especially viral infections and bacterial infections, are a big thing to look for in people with chronic obstructive lung disease when they come with exacerbations. So look for infections. Common organisms are Haemophilus influenza and pneumococcus. That's why these people, it's very important to give them the pneumococcal vaccine every 5 years. Every 5 years they should get the pneumococcal vaccine, and they should get the influenza viral vaccine yearly. Very important for them to get vaccines. The most common form of infection that produces a COPD exacerbation are not bacterial infections. They are viral infections. But when you have a question, maybe it's better to treat the patient with antibiotics. Okay? So you will see this commonly clinically done when the patient is admitted to the hospital. Not do they only treat the COPD exacerbation with bronchodilators, but they give the patient antibiotics. Good. Chronically, there's only 2 things that you could do to these patients to improve their outcomes. Only 2 things. Only 2 things have been shown to change mortality in these patients. In the acute exacerbation, you give them bronchodilators. But over time, chronically, none of these things have shown to make a difference. There's only 2 things. So, decreased mortality in people with chronic obstructive lung disease is done by 2 things. Number 1 is to stop smoking. That's number 1. If you look at people that are smokers and you look at lung function, you look at lung function and it goes down like this. So this is lung function and this is time. If you stop smoking in these patients, you see something like this. Big difference. So this person, the same person, stopped tobacco, stopped smoking, was a smoker before. This person continued smoking. Same person. So big difference there. So that's one thing. Stop smoking. Okay? Not all patients with COPD are smokers. Most of them are. Not all patients that are smokers will get COPD. A lot of them will. So there's other things involved here. But a lot of these people, they're smokers. Definitely you need to stop smoking. The second thing is to give them home oxygen. Home oxygen. I don't mean that when the patient comes in with a COPD exacerbation and is short of breath and so forth, and you're treating them for an infection and so forth, there you give them oxygen. Yeah, you give them a little bit of oxygen there so he or she could feel better. But I'm talking about in the long run. How do you make this person have less mortality? And home oxygen is one way. It seems that the pulmonary hypertension that develops with chronic obstructive lung disease causes right-sided pressures to be elevated. So cor pulmonale and right-sided heart failure is a major reason these people die. So by giving home oxygen, you decrease the hypoxemia and probably decrease the pulmonary hypertension. It is only the people with severe chronic obstructive lung disease that benefit from this. What are those people? The people that when you check their oxygen at rest will have a PaO2 of less than 55. If you check their oxygen at rest and their PaO2 is less than 55, they get home oxygen. How much home oxygen? As much as they could tolerate. If they could tolerate it 24 hours, 24 hours is better than 12 hours. If they could tolerate it only 12 hours, 12 hours is better than 6 hours, as much as they could tolerate. Sometimes it's very difficult to keep a patient 24 hours a day on home oxygen. Very difficult. If you had a choice when to use the home oxygen, you always tell them to try to put it on at least at night. At night, everybody desaturates. We all do. Normal people. Their oxygen pressures go down. These people desaturate even more. So when their oxygen goes down, pulmonary pressures go even higher. So if you could do one and only one thing, tell them to keep it on at night. This is the most important category here. Now we give home oxygen to a couple more people, and the other people is if your PaO2 is between 56, say, and 59 or 60, plus you have cor pulmonale, right-sided heart failure, this person deserves home oxygen too. Now, they're not going to tell you this person has cor pulmonale. You're going to have to find that on the physical exam. What would be signs consistent with right-sided heart failure? Jugular venous distension, edema, and so forth. Okay? It may not be that the patient has left-sided failure. It may not be. Sometimes they do, but sometimes they don't. So be careful about that. So jugular venous distension, edema, lower extremity edema, these are signs of cor pulmonale right-sided heart failure. And there is one more category that, so let me just recap here. In these two categories, both of these, you try to keep the oxygen on the patient as much as possible. But especially at night, both of these categories. Very important. There's one third category that sometimes you may need to know, and there are groups of patients with chronic obstructive lung disease that have significant desaturation with exercise. And I mean that if these people, you check their oxygen at rest, you find that their PaO2 is above 60. It's okay. They don't deserve home oxygen. But they tell you, every time I walk a small flight of stairs, every time I walk quickly across the street, I get really short of breath. And there's a percent of patients with chronic obstructive lung disease that they desaturate, their oxygen drops really quick when they exercise. So what do you do to that patient? You make them walk a flight of stairs or two. You check their oxygen now. And if you find that they desaturate significantly to really low rates like this, you give them the oxygen only with exercise. So desaturation with exercise is a third category that you give them home oxygen. Now this is, though, these people should get it only when? Only when they exercise, because otherwise they have normal oxygen pressures. Well, not normal, but ones that don't deserve home O2. So they only get it here with exercise. So these three categories are the three things, the three categories that you should know that you could change mortality in. We could only change mortality by cessation of smoking and home O2 in the categories that deserve that. Okay? The significant patients, the significant COPDers. They may ask you on the boards about the best way to assess how bad the disease is. And the answer to that is you take the FEV1 from the pulmonary function test, and this is your best parameter of, you want to stratify how bad the disease is on a patient. This is your best parameter. If the FEV1 is less than 50% of predicted, I know that this patient could tolerate most exercise, right? But if they do a little bit more than just the daily chores and stuff like that, they get short of breath. I know that if a patient has less than 25% of predicted, then if you make them walk across this room really quick, they have a hard time doing it. So the FEV1 lets me stratify the severity of disease. This is the best way to stratify severity of disease, the FEV1. Okay? Good. Now, what are other treatments that we do in people with chronic obstructive lung disease? Well, one is the bronchodilators. We use bronchodilators in these patients. They don't change mortality. They do not. Bronchodilators in these patients do not change mortality. The bronchodilators of choice are things like ipratropium, anticholinergics. They are more long-acting than albuterol, and they don't have that quick relief response. But you don't need that quick relief response because remember, these people are non-reversible. So you give them the bronchodilators to really cause minimal changes. Maybe going from an FEV1 of 30% of predicted to 35% of predicted, right? Remember when we gave the albuterol before? We didn't see much change. But those small changes sometimes make the patient feel really good. They make the patient really feel good. So this is a treatment of choice. These kind of bronchodilators. They do not change mortality. They are only for symptoms. They make the patient feel better. A thing that has come up to surface again now is theophylline. Now theophylline has gone back and forth. Now it's in vogue again. So this is the reason, because some studies showed that when you put the patient on theophylline, the people with chronic obstructive lung disease, we didn't use it in asthma, only in the severe exacerbation. We don't use it in asthma. It's only COPD that we like to use it. People that were on theophylline regimen plus other stuff felt better. Their exercise capacity was better than the other patients, even though they have severe COPD. And it seems to be that theophylline is not a great bronchodilator. Not a great bronchodilator. So it's not that effect that probably makes the patient feel better. It's some other stuff. it makes the diaphragm work better. So the muscles work better. The heart works better. It has this cardiotonic effect. So theophylline works. That's the bottom line. So you may hear about using it in chronic obstructive lung disease. This doesn't change mortality. Again, it is only for the symptoms. So this is your treatment of a patient with chronic obstructive lung disease. Do we use steroids? No. This is not an inflammatory disease. We don't use steroids in the chronic treatment, unless the patient has coexisting asthma. That's rare. You're not going to be asked about that. Now, this is the chronic treatment of chronic bronchitis and emphysema. A lot of these patients come in with acute exacerbations. They come in with acute exacerbations, usually, we said, from upper respiratory tract infections, usually from viral syndromes, usually. In that case, the treatment here is giving them oxygen, bronchodilators, and theophylline. But now, in the acute exacerbation, there seems to be a significant inflammatory component. So, in the acute exacerbation only, there seems to be inflammation. So, studies, well randomized, well done studies, have shown that in the acute exacerbation, you, the patient, will benefit by you giving them a spurt of steroids, just like we did with the asthmatic patient. So remember how we treated the acute asthma exacerbation? We gave him bronchodilators, we gave him oxygen, and we gave him steroids. So in the acute exacerbation for COPD, the treatment is similar. It is similar. You give a different bronchodilator, okay. You may give him some theophylline on top of that, that's okay. But you also give him steroids. For how long? The same thing you gave for the asthma, about 14 days, and then you stop it. Remember, there is no role, for your purpose, there is no role of chronic steroid treatment in COPD, only as an intense regimen in the acute exacerbation. And that's all. Okay? Very good. I want to tell you one last thing here, and then we'll go back and finish up the case. There is a form of emphysema. This patient had emphysema here. So we treated him exactly like here. There is a form of emphysema that occurs in young individuals. It usually affects the lower lobes. Very important to know this because this is sometimes reversible. It is also associated with liver abnormalities, and this is called alpha-1 antitrypsin deficiency. So if they give you a young patient, 30, 35-year-old patient with emphysema, especially involving the lower lobes, plus at the same time you look somewhere there and you find liver enzyme elevation, then you think about alpha-1 antitrypsin deficiency. This is possibly treatable. They get alpha-1 antitrypsin. Okay? So just think about that in the young patient. Very good. So I want to go back to the case here. On the second page of the case, we've diagnosed that this patient has emphysema by the pulmonary function testing, and we checked the sputum. We made sure that there is no infection in this patient. Grew Haemophilus influenza, so maybe there was a reason for this patient to get antibiotics too. So let's see their treatment plan. They gave the patient inhaled bronchodilators, right, beta agonists, and anticholinergic agents. So we said first line in COPD are the anticholinergic agents. Sometimes you may give albuterol with that in the acute exacerbation. It's okay to do that. Oral antibiotics, if you're thinking that the patient has some kind of infection, especially with Haemophilus influenza. And remember, I want you to put a little star here where it says corticosteroids. You give corticosteroids only in the acute exacerbation for about 2 weeks or so. oxygen to maintain O2 saturation approximately 90%. So they gave just enough oxygen to maintain the saturation at 90% on the pulse oximeter. Why? Because if you go over that, you increase the oxygen enough, you blunt the respiratory rate. Now this patient gets more CO2 retention. So keep in mind the CO2 retention in these patients if you increase the oxygen too much. And you consider mechanical ventilation if the patient in only severe cases. Good. So the chronic treatment we said is stop smoking and HOMO2 if the patient deserves it, and inhale bronchodilators. So that's our case. In the next page, it said consider a patient with emphysema, compare her with a patient with chronic bronchitis. List the differences between these two patients. So let's talk about the differences here. The patient with emphysema, they will be clinically, they will have labored breathing. They breathe fast. They look clinically bad. The people with chronic bronchitis, unless they have an exacerbation, they look clinically comfortable. They're usually a little bit obese, a little bit plump. They look plethoric in the face because of the chronic hypoxemia causes secondary erythrocytosis. When you check the ABG in a patient with emphysema, it is almost normal. Especially in the beginning stages of emphysema, it's almost normal. The patients with chronic bronchitis will have chronic CO2 retention. So they look good, but their ABG looks really bad. The definition of emphysema means that they have destruction of the alveolar membranes. So when you compare the pulmonary function test of somebody with emphysema to chronic bronchitis, you will see that the DLCO is decreased in this patient. The patient with chronic bronchitis will have a normal DLCO. Also, the last thing is that people with emphysema have a worse prognosis. Emphysema patients have worse prognosis than chronic bronchitis. Okay? Otherwise, they're treated the same way. Very good. So, going a little bit further down to case number 4. This is a 25-year-old woman comes to the clinic complaining of cough off and on for about a year. The cough is non-productive. It has worsened in the last 4 months. She feels tired, has occasional low-grade fever, mild dyspnea on exertion, and has lost about 5 pounds. The patient has no history of asthma or tobacco use. She has experienced intermittent pain in her shoulders and knees. She also has noticed that her vision has worsened in the last 2 weeks. She's well nourished and is no acute distress. There are mobile and enlarged anterior cervical and epitrochlear lymph nodes. Pulmonary examination reveals bilateral dry crackles. She has knee pain with motion. And she has these painful red nodules that are seen in the anterior aspect of the legs. So chronic cough, blurry vision, lymphadenopathy, and now you have these painful red nodules in the anterior aspect of the legs. This, they're trying to tell you, this is likely erythema nodosum. Now, erythema nodosum, we should know a little bit about the differential diagnosis of that in terms of what diseases does it occur with. And we know it occurs with tuberculosis, it occurs with sarcoidosis, it occurs with inflammatory bowel disease, and then some common infections like strep and staph. But the two first ones are the most important ones to rule out right away, sarcoidosis and TB. So always in these people, your first two differentials with erythema nodosum, especially if they have some pulmonary syndrome, is TB and sarcoidosis. Now this person has likely sarcoidosis. Why? Because she also has arthritis and she also has blurry vision. Right? That occurs with sarcoidosis, uveitis. So they complain of blurry vision. So that's definitely on the top of our list here. So, and erythema nodosum could also occur with lymphomas. So this patient with the lymphadenopathy is definitely something to think about. So tuberculosis, they said in the differential diagnosis, yes, it causes arthritis. Sometimes tuberculosis does, but it's usually a monoarthritis. It's usually a monoarthritis. And it should have been more concise disease, maybe a month and a half. You usually don't have TB for a year. Usually not for a year. This is usually more consistent with tuberculosis. Lymphoma, especially Hodgkin's disease, they could do that sometimes too. So you find shoddy lymphadenopathy, some lung process, but not the dry crackles. It doesn't usually cause uveitis. It could cause erythema nodosum, though. So that's definitely a thing to think about. And then some diseases like collagen vascular diseases, like systemic lupus erythematosus, you should definitely think of that too, especially with the arthritis. They usually don't cause uveitis. They usually don't cause erythema nodosum. It's usually other types of rashes, either the photosensitivity rash or the malar rash or the discoid lupus rash that we see in diseases like that. So always, in a patient with erythema nodosum, 2 tests have to be done initially. 2 very important tests. And you diagnose most of the diseases. One is the chest x-ray. The second one is to place a PPD. If you do those 2, you take care of the 3 more important things here: lymphoma, sarcoid, and tuberculosis. So that's what they did here, and they did a complete blood count, and they placed a PPD also. And, of course, they did a little bit more. They get the acid-fast bacillus and sputum culture, but really, unless you see something on the x-ray, that's not needed. And you got the anti-nuclear antibodies to rule out things like lupus. So on the results here, we go a little further down, and you find that this patient on the chest x-ray has symmetrical bilateral hilar lymph nodes and normal lung parenchyma. So it looks kind of like this. Let me take this off. It looks here's the chest x-ray of this patient, and you find the bilateral hilar lymph nodes. There's nothing on the parenchyma, there's nothing on the apices. Usually lymphoma has lymph nodes that are symmetrical because it usually starts on one side. So you find big lymph nodes here, maybe a small one there. That's what lymphoma. This is likely sarcoidosis. When you find symmetrical hilar adenopathy. This may be lymphoma. It may also be tuberculosis. Tuberculosis, though, looks like this. Post-primary TB looks like this. There's something in the apex. Now remember, in the PA and lateral, it's difficult to look at the apices, so this is not going to look that clear-cut here. It's going to look a little bit hazy, and you're going to have to get what is called a lordotic view, where they shoot into the apices and they look at the apices more closely. So this is TB, and of course, on the side where the TB is, you may have hilar adenopathy. You may have. So this is TB. This is lymphoma. This is sarcoidosis. So a little bit further down, you check the PPD, and it's less than 5 millimeters. So this makes it more likely that this is sarcoidosis. Now, what do we know about sarcoidosis? We know that it is a granulomatous disease. It is a chronic granulomatous disease. It occurs with symptoms over months, sometimes years. The patient tells you, I've had a long time where I've been feeling bad, I've been feeling a little bit fatigued, I've been feeling a little bit with this cough, non-productive cough, and some other symptoms, and it's been going on for a long time. And eventually they come in with some specific issue, like this patient did with erythema nodosum and the arthritis. So it's a chronic granulomatous disease. We don't know the etiology. It may be an environmental agent in susceptible people. It may be an infectious agent in susceptible people that causes this. But the granulomas that we see with sarcoid are a little bit different than the granulomas that we see with TB. These are usually non-caseating granulomas. So sarcoidosis causes non-caseating granulomas. TB usually causes caseating granulomas. Sarcoidosis cause stage 1 sarcoid causes equal adenopathy, hilar adenopathy. TB usually doesn't. It usually has unequal lymphadenopathy, and it's usually something in the apical region because this is post-primary TB. So a chronic granulomatous disease that presents with multi-system involvement. The lung is the most common organ affected. Almost all patients, 80-90% of them, have some kind of lung involvement with sarcoidosis. Other organs involved are the joints, the skin, sometimes with erythema nodosum, and some other things called lupus pernio that affect the face, a rash over the face, uveitis, so this is important, uveitis, and sometimes another important finding is hypercalcemia. This hypercalcemia occurs because of an increase activation of vitamin D through the granulomas. So in a way, it's a form of hypervitaminosis D. The granulomas activate vitamin D more commonly this way when the sarcoid is active. People get more vitamin D usually in the summertime. So sometimes these people get the hypercalcemia during the sunny months of the year because there's two ways you could absorb vitamin D. One is through the diet, and the other one is through the skin, through sunlight. So they get more vitamin D this way, they get it activated more, and they develop hypercalcemia. And the third way it presents for your purposes, it has multiple manifestations, but these are the things that they like to ask, is this thing called acute sarcoid or Lofgren syndrome. Lofgren syndrome. Lofgren syndrome is the triad of arthritis, just like our patient, erythema nodosum, just like our patient, and hyalaretinopathy. So this patient had an acute form of sarcoidosis called Lofgren syndrome. The reason I told you about these three presentations of sarcoidosis is because they also happen to be the three diseases or the three presentations of sarcoid that we are really aggressive about treating. Treating usually means giving the patient steroids. If you don't give the patient steroids with the uveitis, they scar their eye and sometimes develop blindness. If you don't treat the hypercalcemia, they get altered mental status, they get severe dehydration, and so forth. So these are the three forms that we like to treat with steroids. The pulmonary disease is a little bit different, and there's a big question here. Who should you treat with pulmonary sarcoid? And the question, the jury's not out. We don't know. So, because 80% of patients with pulmonary sarcoid will either remain the same, remain unchanged, or get better on their own. On their own, without anything else. So, you're a little bit less aggressive with the lung disease unless it's very active. Please be careful. When they talk about sarcoidosis in the lung, they may talk about stages of disease. This is considered stage 1, the hilar, equal lymphadenopathy. Stage 2 is hyalaretinopathy and parenchymal involvement. Stage 3 is just parenchymal involvement, and stage 4 is fibrosis and what is called burnt out sarcoid. Please be careful that this is not like cancer. it doesn't progress from stage 1 to 2 to 3. When they refer to stages of sarcoid, they're really telling you where the involvement is. So you get an idea of where the involvement of the sarcoid is. So stages do not tell you about prognosis and aggressiveness of disease. It's not like cancer. They're just really telling you where the disease involves. So be careful about that. Stage 2 may be worse than stage 3, and so forth. So it has nothing to do with that. You don't have to know the stages. You have to know that it does not necessarily mean that stage 3 is a more progressive stage than stage 1 or 2 or so forth. Okay? It has nothing to do with that. Okay. So, very good. So, this is sarcoid, and if we go back here and you see that the rest of the exam here, the initial diagnostic plan was normal, complete blood count, the PPD and the acid-fast bacillus of sputum were normal, and of course the anti-nuclear antibodies were normal. If you want to definitively diagnose sarcoidosis, what do? You take the lymph node out, you biopsy the whole lymph node, because what do you want to rule out, especially here? Lymphoma. And if you do fine needle aspiration, you're going to miss that. So you want to take the whole lymph node out and look at it under microscope. Make sure they don't have Reed-Sternberg cells in there. Nothing to show that this is Hodgkin's. Nothing to show that these are caseating granulomas and acid-fast bacilli to point towards TB. If you find that this is a non-caseating granuloma and nothing else, you've pretty much documented sarcoid. Please remember, there is no definitive test for sarcoid. It is a clinical presentation plus the finding of non-caseating granulomas on the biopsy. Non-caseating granulomas, though, occur in many other diseases. So there's nothing definitive. Angiotensin-converting enzyme levels have been used by many to diagnose sarcoid or to presume this is sarcoid. These are non-sensitive and non-specific. They have no value in the diagnosis of sarcoid. They may be used sometimes in certain patients with sarcoidosis, already documented sarcoidosis, to look for exacerbations of disease. So ACE level comes up, you know that this is the reason this patient's feeling bad, because their sarcoid is coming back. Okay? They should not be used, I repeat again, in diagnosing the disease. Okay? Last thing I'm going to talk to you about here with sarcoidosis, and I'm going to finish and take a break, is this. Stage 1 sarcoid, right here, is the most common presentation of the disease. That's what you find most of the time. Most of the time, it's found on a routine X-ray, and the patient has no symptoms. So this is an asymptomatic patient, no symptoms. If the patient comes to you with no symptoms and equal hilar adenopathy, no symptoms, you assume this is sarcoid. What do? You do nothing further. You watch the patient. Watch. Repeat the X-ray in 6 months. Follow up in 3-4 months. Make sure that the patient doesn't develop any symptoms. It's okay to do that. Okay? So you don't have to be aggressive if this looks like sarcoid on the X-ray, hilar equal adenopathy, and no symptoms. Okay? So I'm going to stop there, and we'll take a little break and come back and start with case number 5.